The National Institutes of Health cautions that most genetic tests today are not regulated, meaning that they go to market without any independent analysis to verify the claims of the seller. They further state, since clinical genomics is a relatively new field, frameworks to evaluate the clinical utility of genetic tests are still being developed. With time and experience, researchers, clinicians, health insurance companies, and regulators will have better information with which to establish the clinical utility of genetic tests. One major aspect of clinical utility for genetic testing is gene selection. You may be surprised to learn that there are genes on some comprehensive hereditary cancer tests that have very limited evidence for association with cancer. Clinical laboratories make their own choices for which genes and which regions of genes are included in their testing panels. Some CLIA and CAP accredited labs keep their genetic panels limited to mostly genes with strong evidence and clinical guidelines for patient care. Other CLIA and CAP accredited labs take a bigger is better approach and include genes with limited or emerging evidence, which may result in false positives. Pathogenic variants in a gene selected from the emerging research literature would actually be false positive variants if the entire gene is eventually demonstrated to be unrelated to cancer. We know that research conclusions most often disproven through replication studies are those coming from emerging research literature. Even when gene-disease associations are not disproven, it is still common for the estimated disease risk associated with a particular gene to diminish as investigators learn more. Also, as gene panels get bigger, the chance that a positive test result is a true positive drops. This is because more variants are discovered on larger panels, resulting in greater opportunity for false positive variant classification. For more information on this phenomena and how it impacts minority populations disproportionately, please check out the other videos at testwisely.org. To demonstrate the variability in gene selection on tests, the Center for Genomic Interpretation reviewed several comprehensive hereditary cancer panels available from CLIA and CAP accredited labs. These similarly described panels ranged in size from 34 to 154 genes. The center's researchers then looked at each gene to count the number of publications in PubMed that contained the gene name and the words dealing with cancer. Using the publication count as a blunt measure of evidence thresholds, the 34-gene hereditary cancer panel had a minimum threshold of 203 publications for gene inclusion, whereas the larger 154-gene panel had a minimum threshold of 5 publications. The likelihood is extremely small that a gene with only 5 cancer-associated publications has enough replicated clinical studies to assist a clinician in providing high-quality medical care to seemingly impacted patients. But what about the insurance payers? Certainly, they block payments for tests that have too many low-evidence genes on them. Well, no. In fact, most genes on panels are hidden from insurance payer view through the magic of low-information billing codes. So it is entirely left to clinicians to act as their own regulators to ensure the safety of their patients when selecting and using genetic tests. Most clinical genetic counselors are eager for clinical labs to provide transparent and easy-to-understand explanations of their evidence thresholds for gene inclusion. Standardized frameworks for these evaluations were made available in 2017 by the NIH-funded ClinGen Consortium. We would like labs to proactively use these or similar frameworks for gene evaluations, and to keep these data public and up to date. We note that sometimes evidence emerges which should remove genes from panels or change clinical utility, and we'd hope that laboratories would keep their panels and marketing current. Clinicians should be made aware of which genes on panels have or lack clinical care guidelines. It should also be clear which genes are well established and which are not. Transparency and evidence thresholds of gene selection for panels is necessary to ensure high-quality patient care. We encourage labs to be vigilant in communicating this information as they market their genetic tests to clinicians. We also encourage clinicians who are less familiar with genetics to consult with genetic counselors when making decisions about lab and test selections.